it is.
Okay, thank you. So ECOR is nothing but a partial respiratory support. For what it is used? It is because it achieves the removal of carbon dioxide from the blood. And what are we going to do is low blood flow, through a low blood flow, that is almost around less than 1 liter per minute, without significant effect on blood oxygenation. Now, on ECOR, you are not getting the oxygenation and you are using lesser blood flow and you are actually targeting a carbon dioxide removal. Now, when ECOR came into the picture with the ECMO, the idea was not using this technique for carbon dioxide removal. It was a technique to be used for the preservation of the lung function or to prevent the barotrauma or the volutrauma. Now, if we go back to the first ECOR used way back to 1977, the Theodore Kolob and the Gattinoni, who has actually this paper with the control of breathing using extracorporeal membrane. So they have flowed the blood through the membrane lungs and stopped the breathing from there. And then they have seen that there is a control of bleeding and was proportional to the alveolar ventilation was with the fraction of total carbon dioxide removal by the membrane lung. When ECOR removal is useful in management of ventilatory problems like primary with uncontrolled bronchopleural fistula and those conditions where with artificial ventilator is not desired or contraindicated. So ECOR was using in these situations. Now, another study with the ECOR with low positive pressure ventilation, low frequency positive ventilation, they also found the mortality, the use of ECOR in preserving of the lung from the barotrauma. Now, in 2000, in New England Journal of Medicine, the mortality they have with that ARDS net trial shows the lower tidal volume is very much essential in ARDS. Now, with that thing, the use of ECOR in permissive hypercapnia is being established. Now, in lung protective ventilation, when we are using a tidal volume of lesser than 6 ml per kg, the permissive hypercapnia starts. So whenever you are using ultra protective lung ventilation to keep a plateau pressure less than 25, further hypercapnia increases. And the results of hypercapnia causes a lot of pulmonary vasoconstrictions, increased RV dysfunction and RV failure. So the idea of using ECOR with low tidal volume ventilation or ultra low tidal volume ventilation is because of the lung protection and reduction in the bronchoalveolar inflammatory cytokines in the decap group. The decap is a method of using ECOR at that point of time. So lots of paper came with using 3 ml per kg tidal volume strategy with ECOR, and they have used the pumpless extracorporeal lung assist where the pump was not there, the oxygenator was there only in the Germany. Now, in supernova study, which is done by the Alan Coombs, they have also used the feasibility, they have tried to show the feasibility and safety of extracorporeal CO2 removal to enhance the protective ventilation in acute respiratory syndrome. And then they have used the 4 ml per kg tidal volume, a P-plat of less than 25 in moderate ARDS, and they have used the lower and higher CO2 extraction devices. And the proportion of patients achieve ultra-protective lung ventilation by 8 hours and 24 hours have been recorded respectively. The ECOR was maintained for 5 days, and a lot of adverse events they have noted, but there was a 59 patients were alive till discharge. Now, if you see the, that is another study, there's ECLAIR study, which again showed in another cohort the use of ECOR in COPD patients whom are unresponsive to non-invasive ventilation for acute hypercapnia. So they have two cohorts. One is the ARDS patient to improve them with the lower tidal volume strategy for the management of permissive hypercapnia, and there is another cohort of COPD patients who are unresponsive to non-invasive ventilation and to avoid ventilation for hypercapnic episodes. So ECOR has two distinct indications. Now, use of venovenous ECOR has been came to play in subsequent studies, and they have established the pathophysical rationale of ECOR in COPD exacerbations, that ECOR, by using ECOR, there is a decreased alveolar ventilation demand, there is a decreased low respiratory rate and increased expiratory time. So this causes reduced muscle fatigue and decrease in CO2 production. Another arm, the reduced dynamic hyperinflation and increase the CO2 elimination. Now, as you know, the CO2 is the most soluble thing than the oxygen, and it only needs a 500 ml of flow to take out the whole CO2 what we produce every day. And there is a distinct phenomena you can observe, that initial rapid response, if you start ECOR at the level of 100 pCO2, the initial 20 will come down immediately. The 100 to 80 will be an immediate response. Then this 80 to 60 or 55 will be a late response, which is a very gradual response. Now, as we know, the ECOR needs only need 240 ml of this oxygen per minute, and so with the 500 ml of flow, it is not possible to oxygenate the patient. So if you want to oxygenate, you have to put the patient on ECMO. Now ECOR with an AV ECOR, it had VV ECOR and modern VV ECOR techniques. Now most commonly we are using the VV ECOR techniques. Out of that, the AV ECOR is a pumpless system, and it is actually without any pump, and it is connected to an artery, and the vein arterial pressure is actually the driving force to the oxygenator, and you can see it can be pushed in the two groins, the artery and the vein. Now VV ECOR has this whole lot of machines. That's the ILA active, decap system, pump assisted lung protection, PALP, and the hemolung. Now with that thing, ILA active has a various range of 0.5 to 4.5 liter per minute. You can give almost an ECMO like flow. Decap is one of the very good system and very reproducible, shows a lung membrane and the hemofilter down that, and the patient's blood is crossed from here, from the patient, it goes to the membrane lung, and then the hemofilter, the fluid from the hemofilter again goes back retrogradely to the membrane lung to maintain its fluidity. So it is one of the very good technique what we use regularly, and it is coupled, the membrane lung and hemofilter is coupled in series to improve the performance of the membrane lung. The CO2 removal is better with the decap system. Now pump assisted lung protection, the PALP is again by using the Mackay's Cardio Health console, and hemolung system is another technique for ECOR, which are very costly things, but not become very much popular. Now, even you can do the ECOR with the CRRT. If your CRRT circuit, you can put the membrane lung, and there is a sweep gas in and sweep gas out if you can connect with that. Now, reported adverse events are mostly with the dialysis, like the bleeding from the cannulation side, hematomas, venous thrombosis, heat, and hemolysis. Uses are mostly, as I told you, that there are two cohorts, mostly in the ARDS to prevent the lung injury, the lung protective techniques, and one is the COPD to prevent their intubations when they are retaining the carbon dioxide. Now, if you can see the circuit, what we do, we just take a help of the roller pump, and the blood comes out. It goes from the patient, it goes from the roller pump to the oxygenator where there is an inlet connector, and we use the pediatric oxygenator, but the regular oxygenator for 48 hours, and then it goes back to the patient. Now, Prisma lung is one of the thing which has not been installed in India. That is a CRRT machine with which you have a CRRT filter and a membrane lung which is connected, both for the blood gas exchange and for the dialysis of the CRRT will be ongoing. This is the Prisma lung. Now, I'll show the few cases. That is case one, the 28-year-old male, fever for 3 days, respiratory distress. had an ARDS kind of X-ray, intubated, but the oxygenation improved. The carbon dioxide started mounting up. The carbon dioxide 78 with the pH not improving, and we have connected this patient on ECOR using the regular dialysis machine with the pediatric oxygenator in the series with the dialysis filter. Now you can see the technique what we're using. Patient is getting a normal dialysis with the normal filter and a membrane lung, which is a pediatric oxygenator connected in the series. And this is the way, this is the membrane lung, and this is your the dialysis membrane. So these two are connected in series. Blood is going from here to get oxygenated, then goes back, carbon dioxide removal is done in that oxygenator, and the blood goes to the and it goes to the through the dialysis machine, and the CO2 comes out along with the dialysis. Now, and you can see it very clearly. This is the membrane lung. There is a blood out. There is a blood in, and sweep gas is connected here. Sweep gases acts as a CO2 removal mechanism. Now, case study 2, which is the patient actually came with a fever, cough, and running nose, got intubated, a ventilator set on CVC mode, and look at the X-ray. There is a dynamic hyperinflation. CO2 started mounting up. The CO2 is 93, pH was 7.26, and oxygenation was fine. We tried to maintain with ventilatory adjustments, and but the EtCO2 never came down below 70. So we thought we should put him on ECOR. ECOR started on day 5, and it continued for another 7 days. ECOR. This is the system. This is using another dialysis machine with the. This is the membrane lung which is connected without the dialysis filter. So this is the way it is connected with the normal dialysis machine, and this roller pump is the driving force for the carbon dioxide removal, and this is the flow which we are giving around 300 to 350 ml per minute. The CO2 started coming down. The EtCO2 is 66 from 70, and we have used sevoflurane to give for this dynamic hyperinflation. The spasm, it reduced slowly. Look at the ventilator kept on standby mode, and it is actually getting ventilated with the anesthesia ventilated with the sevoflurane, and ECOR is going on the same patient. The ECOR started working. The CO2 came down from 93 to 62, 73, then 92, then again 42 is the last on the day 4. It continued to day 11. We changed the oxygenator once. Day 13, the lungs started improving, and we the final day of ECOR, the 9th day of ECOR, the saturation maintaining, the carbon dioxide went down to it was around 42, maintaining well, and the lungs is looking good, normal. The dynamic inflation and the spasm went off, and we put him on pressure support, removing the ECOR, and this is the ABG on pressure support. We extubated this patient, 40 PCO2, 138 PO2, and 39 is the EtCO2, and we extubated him. So this is a case where the dynamic hypertension, the asthma patient with the retaining CO2, we managed. Now this is a case that I told you, the cohort of the COPD patient. He got actually admitted 8 times in our hospital with a carbon dioxide of more than 100, become drowsy. So this time when he got intubated, got admitted, the relatives didn't want to put him on ventilator. The CO2 was more than 100. He was completely drowsy. So we gave an offer that we should go for an awake ECOR and this kind of patients. And how do we do this? If you can follow the video. The flow is around 250 ml, and ECOR is going on. The patient to the femoral dialysis line, and patient is talking with us. We took out the carbon dioxide by giving the awake cord, and 80 on the patient was on NIV, and we avoided the intubation. Patient became awake, and he's maintained well on the awake cord. You can see in the video. This awake cord going on, 250 ml of flow. With the normal dialysis machine, this is the oxygenator, which is connected. This is a sweet gas going on. And the patient is talking. NIV is not required. We continued the ECOG till his acute exacerbation COPD actually resolves. Now, where do we stand on practicing ECOG? As all of you can practice ECOG because it needs a dialysis machine only, not a very good knowledge of ECMO is required. But my suggestions, and after using a lot of ECOGs in the practice, that use judiciously in selective hypercapnias, avoid MODs, because the primary goal you might have achieved, that the outcome might not be very good in MODs patients. So in selective hypercapnias, you can use the ECOG. Use the femoral access mandatorily, because there are less fluctuations in blood flow and the circuit clot is not much if you are using the femoral access. Because in the neck, if the patient is restless and patient is not doing well, the flow is not very good, and there is a microclot with the microstasis is going on inside the circuit, it is cumbersome. So use femoral access whenever possible, larger access. Use of large bore cannula. Sometimes these dialysis catheters are not very good in the flow. You might need to go up in the flow to 400, 500 ml. The ParmaCath in the femorals, which goes up to the IVC, is the best one. Use that thing. That is 14.5 French ParmaCath is a good option, and you can give a hassle-free ECOG run for about 48 to 72 hours with your technique of decap, and this is very much helpful. Use liberal heparin first to keep ACT around 200. Don't be miser on it, because the flow is low, you are using lesser heparin. That should not happen. So you should give a lot of heparin to to make your things fluidic, and it should be a hassle-free ECOG. Sweep gas flow should be 8 to 10 liters. It is connected with the flow meter in the wall, and you come down on a sweep gas if your carbon dioxide is carbon dioxide is reducing. Flow target should be kept around 300 ml per minute. With that flow, you can maintain a good carbon dioxide removal over a period of time. So target is always to maintain more than 300 ml. You can go up further, but should not be less than 300. The circuit clot and the ineffective ECOG can happen. So thank you. If we can come to the